بسم الله الرحمن الرحيم. أبنائي وبناتي طلبة سنة خامسة. اليوم هنتكلم على السيلابس تبع Clinical Urology. As you know, already we delivered the lectures of cognitive knowledge about the urology sciences in the Faculty of Medicine at the start of the year. By this presentation, we shall concentrate into three main topics. The first one is clinical presentations of urology patients, that's to say, symptoms and signs of the patients at different ages and groups. Number two will be urology cases related investigations, that's to say, imaging techniques, blood and urine studies, in addition to different entities. Then at the end, we shall talk about, we selected some clinical cases so as to discuss and be oriented with that, how patients could be presented. For the first topic, that's to say the clinical presentations of urology patients, to start with, uh, uh, as you know, just the approach to any a clinical case including the urology, we are not to forget to take complete history from any patient presented to us, either from the patient, him or herself, or the next of kin assigned or coming with the patient. To start with, personal history must be taken very accurately and in details really, because any patient by any group or type of work or living somewhere here or there could be present with some disease related to, to him or her. Then the presenting complaint itself and its duration had to be mentioned clearly. Then coming to the history present illness, analysis of this presenting complaint, then coming to the systematic review of this patient, then coming to the past history, including the medical and surgical, of course, a drug intake, allergies, and blood transfusions had to be known to the treating surgeon. Then coming to the family history, many of diseases of the kidney or urology system could be inherited familially. So it's good to know, uh, yeah, to have an idea about the family history. Then social status of the patient, being married and for how long and how many kids. The socioeconomic status of any patient is to be assessed by any history taking. Now, before going to the details of the presenting symptom of the patient, let's just have a general idea about the anatomy of the urology system. Of course, we are having two kidneys, two ureters, of course. We are having a bladder. We are having a bladder neck. We are having a urethra with its two parts, the posterior urethra and the anterior urethra, and its part is having its relating impacts. For the kidney, it's very important to know that the kidney is having two surfaces, anterolateral one and posteromedial one. We are having two poles, the upper pole and the lower pole of the kidney. We are having, two surfaces, the medial surface and the lateral medial border and the lateral border. It is covered by, the capsule of the kidney. Then just to the outer side of the kidney, there is the gyrota fascia, which is very important, just keeping, the kidney in its position. The position of each kidney is, the right kidney is a little bit lower than the left kidney, and this is having a great impact because, clinically speaking, we could feel the lower pole of the right kidney, which is very important to know as a clinical entity. The hilum of the kidney, which is the medial surface of the kidney, the medial border of the kidney, through which coming and going out, going to the kidney are the renal artery of the aorta, just opposite lumbar 2, and just being drained by the renal vein which is being drained to the inferior vena cava, which is very important entity to know. To the upper pole of each kidney, we are having the two suprarenals, and those are very important. On the right side, it's a pyramidal shape, and on the left side, it is crescentic shape. It's nice to know this entity of anatomy. Now, for the gonadal veins, the gonadal vein on the left side is being drained to the left renal vein, and on the right side it is drained direct straight forward to the inferior vena cava, and this is having clinical implications on the theories of pathogenesis of the varicocele being more common on the left side. This is a very important picture of the kidney, just to keep it in mind whenever we are taking a history from our patient, right, left, upper, lower, line or groin, radiation of any pain. So you know the place of any organ the patient presented with, so as to interpret the presentation in a nice way. The group of symptoms of the urinary system, we could divide arbitrary actually the symptoms of the urinary system either to the upper urinary system or the lower urinary system. By lower, roughly is meant with the lower ureters, with the bladder, with the urethra, and the prostate in the male side, and some other related structures in the female. The group of symptoms could be headed by a pain with its different characters according to the site of the pain. You are having urine discoloration, and by urine discoloration, a lot of knowledge could be known about the patient. Disturbance of micturition like dysuria, stream, small stream, or characters of the stream of the urine coming out. The caliber of the urine is very important. Dribbling of urine, frequency, hesitancy, urgency. Some symptoms are specific to the, obstructive urological cases to the urethra or some part of the urinary system. Each one is having its own implication. Retention of urine being acute or chronic, you know, and to differentiate that from urinary incontinence, which is different. And this is coming to the nematuria. Nematuria, that's to say air in the urine coming out. What is the implications for that? Pyuria passing the urine. There is hemospermia. There is anuria or oliguria or polyuria, as we have detailed in our previous lectures. Then coming to the symptoms of UTIs, either upper or lower, symptoms of obstructive uropathy, swellings in relation to the urinary system, and varicocele, just in the it could be primary or secondary in a young man or an elderly, or metastatic complications of, say, renal tumor, which could be metastasized to one of the big lung bones, or could be presented by, say, pathological fracture, symptoms of renal impairment and renal dysfunction, or renal failure, because all of those are very important just to pick it. And coming to the first symptom of the urinary system, pain is very crucial in relation to the urinary system. According to the site of the pain or radiation of the pain, we could know the main source of the urinary system being affected. Say a pain in the loin, this is mostly of renal origin, and this is characterized by being vague, dull, aching pain to one of the loins. By loin is meant the renal angle, either in the left or on the right. If this pain is there mostly in the renal, without being radiating here or there, yes, we will say it's mostly renal, but it is radiating from loin to groin, to the upper part of the thigh, or to the testis even, or labia majora. This is mostly ureteric pain. And ureteric pain is a really sickening pain, characterized by not only this pain, characterized by swelling, by sweating, characterized by tachycardia, characterized by agony, characterized sometimes by the squatting. It's a really sickening pain, this ureteric colic. It is characterized by its this typical radiation we mentioned. If the pain is coming to the tip of the penis or the urethra, this is mostly trigon irritation, trigon of the bladder, or a stain and the ureterocystic junction. So from the site of the pain, we could say that stone could be here or there. So as to request the related investigations like an X-ray, if, if we are talking about a pain at the end of micturition, it could indicate a bladder wall insult on contractions like a bilharzial ovum or something like that, just being contracting, and this ovum would be squeezed and coming out, or some injury on contraction pain could be, exaggerated. If we are talking about strangury, and by that is meant external retching and discomfort at the end of maturation. It could be a symptom of a bladder stone or some infection concomitant with that. This may be due to severe inflammation of the bladder or the urethra. Coming to the suprapubic pain or perineal pain, this is mostly bladder, pelvic, or a prostate pathology. As we have mentioned before, the dull aching pain, this is the typical picture on this one. The patient is coming with the hand on the lung like this, and the patient is putting the hand in there. It's a dull aching pain. This is in the coast of a triple angle, mainly to the left or to the right, upper outer quadrant, and might refer to the hypochondrium. Notice that the pain could refer to the hypochondrium either on the right side or on the left side. Talking about the ureteric pain, look at the radiation of the pain. If from loin to groin to the testes to the vulva, coming some or labia majora, I mean, some tenderness could be in there concerning the relative obstruction, back pressure to the kidney, with guarding but no rigidity sometimes. It's very important to be differentiated from picture of appendicitis or some sort of pyelonephritis sometimes. And of course, there are some other characteristics for the appendicitis, like the tenderness, rebound tenderness, rousing sign, presenting signs of appendicitis. It's really sickening pain, as I mentioned before, and could be associated with vomiting, diarrhea. It's really sickening pain. Coming to the urine discoloration, very important. Just what is the color of your urine? In hematuria patient, and hematuria, as we mentioned, it could be initial, it could be terminal, it could be throughout, it could be intermittent. And by hematuria is meant passage of blood in the urine. It could be gross, microscopic, although initial and terminal. Are discolorations like bile in the urine? The bile in the urine, the patient will coming to you like the patient is coming. Sometimes it could be misinterpreted by the patient, and the patient is coming to you telling you there is some blood, some altered blood in the urine, which is not correct, by the way. Bile in the urine, as we know in Arabic, we are saying sometimes still like عامل زي الشاي يا دكتور البول غامق كتير. A greenish brown urine with a yellow or brown foam. If we shake the urine like this while being in the bag, in the urine bag, it might give a foam, A greenish hue on a standing due to the oxidation of of the bilirubin. The urine could be orange in porphyria, but on long standing it will be an amber colored, topping that. By brownish urine like cascara or senna uh, intake. By reddish urine is meant sometimes by salicylates, which could microscopic, bloody oozing from the urinary tract. By purple discolored urine, those people who are receiving rifampicin, the antibiotic, the anti-tuberculous drug, specifically, it could give a purple urine, and the patient to be notified or to be, told that your urine could be with this color if you are taking this rifampicin or some of the other antibiotics, say It could be green if the patient is being injected or swallowed some dyes like methylene blue. The urine could be beet urea, reddish-like urine, in cherry rotandi or beet eaters, Banjar. A caluria, milky white fat globules with bankruptcy or filariasis sometimes. The discolored, the urine will be discolored like this. This is the way. Always have the urine like it's test tubes being standing and wait for some time till being fixed and look at the color appearance according to the grades of this urine. Sometimes it's clear, it's being turbid, it could be bloody, and the blood could be like this. You just have a look. Only give the description of the urine for the doctors, or the medical staff. By the color of the urine, it might give a big clue for the discoloration. But of course, this will be sent to the laboratory so as to give the specific diagnosis. The other symptoms are the dysuria. By dysuria, different symptoms of passing urine, really. By dysuria is meant pain or discomfort during micturition, plus difficulty in voiding. It may be burning or scalding pain. By disorders of micturition is meant either frequency or hesitancy or urgency. Frequency increased of passage of urine, and this is characteristic sometimes of the patients who could be diabetics, who could be having urethral obstruction, like patients with the prostate, like yeah, some oral prostatitis, or coming to the hesitancy, which is difficulty in initiating urine. The patient will stand for wait for some time to let the urine being passed, being relaxed, then opening the parasympathetic stimulation. At the end, some urine will come out. The usual cause is mostly prostatic obstruction, which prevents entry of sufficient urine into the proximal urethra to initiate the sphincteric relaxations. Coming to the urgency, urgency is the sudden desire to void, which, if ignored, may result in some sort of continence. And it's sometimes does not real incontinence. The patient having, if the patient is with retention with overflow, some drops of urine, and the patient will misinterpret that as being incontinent. In bladder neck irritation or abnormal entry of urine into the proximal urethra will result in some sort of this urgency. Nocturia, which is the need to pass urine at night, passing urine by night. The patient may being awake with an urge to void hourly, sometimes less or more than that. Normally, adults arise no more than twice by night. And this is very important to differentiate, in the kids or some of the children are having some sort of nocturnal enuresis. And by that, it could be due to some psychological or social disturbances, and that entity is to be differentiated from the nocturia uh, being happen pathologically in some of the patients who are, as we have said, the best example for that is the prostatic enlargement or some or the UTIs or diabetic patients with uncontrolled blood sugar level. Coming to the caliber of the urine, a small caliber urine or weak stream, let us say that. And this is very clear. Look at the stream. If we could imagine the streams of the urine passing out, a boy or a young man will pass urine just strongly and at a far distance, even from his side. But in the elderly, it could be a weaker, it would be a small caliber. The diameter of the urethra will be less, so the caliber of the urine will be less. But in the younger age group, there is no obstruction, and the urine will come as uniform and normal caliber, let us say. When there is a urethral obstruction, such as benign prostatic hyperplasia or urethral stricture, as in some young men, really, the urinary stream is reduced. A post-micturition dribbling, and this could be a big problem for some seniors, some elderly, really, and coming with the symptoms of prostatism or prostatic enlargement, and this is really troublesome for the people who are, every now and then they are praying before each salah. The patient will feel that he is not tahir enough, tahir, and he is to have just to have wudu before each prayer if having this problem. But of course, it had to be treated instead of having that frequently. Urinary flow doesn't cease completely at the end of micturition, but some will be having a trouble. This condition may result from abnormal sphincteric functions or voiding incompletely, like really in prostate. Just to complete the list of symptoms in the patients with urinary symptoms, you are to talk about retention of urine. And we are to differentiate very well between the what is known as acute retention of urine, chronic retention of urine, and retention with overflow. With acute retention of urine, it is characterized by being very painful, like a young man with stricture urethra or a stone in his or in his urethra, and causing this acute retention, patient cannot pass urine, and the patient will be presented with a really severe pain, and he cannot pass urine, and the pain is suprapubically, could be radiating here or there to the loins, I mean. And this is in comparison with the chronic retention. By chronic retention is meant that the bladder being accustomed or used to be, retain some urine over long periods, months or years. So the bladder has been accommodated to such big amount of urine being retained in there, and the patient will not have pain. The patient could retain 2 or 3 liters in his or her bladder without having specific complaints, really. This is in comparison to the acute retention of urine. Coming to the retention with overflow, those patients with really obstructed, proximal obstructed urethra, like in prostate, the patient cannot pass urine, and the end he is having this increased frequency, and after by increased frequency, some urine will be passed, he will stop, then after 1 or 2 hours he will go again, and in spite of passing some urine, and in between he is having some sort being retained, the patient, yes, but some drops of urine are coming out, so we are calling this as retention with overflow, and this is very important to put in mind. But please keep in mind, if the patient cannot pass urine, we are to differentiate it very well from a real renal insult, like the patients with anuria or oliguria. We are to differentiate between this retention and oliguria or oliguria or anuria. And by urinary symptoms, really, we are to differentiate. We have different types of urinary incontinence, like continuous stream of urine coming out, or there is an urgency, or stress incontinence, or retention with overflow. It is just, yeah, by patients, it could be interpreted as incontinence, but we are to differentiate the type of your patient. If there is a spinal injury, if there is a prostatic disease, if it's a young man, and if in a damaged urinary sphincters, the urine will be kept flowing, so this incontinence is to be considered very well, to be interpreted. Please listen to the patient well, so as to know what sort of incontinence this patient is having. By stress incontinence, whenever a lady is being laughing, or a young man laughing, or an elderly, some drops of urine are coming out. So, we have to differentiate really. Nematuria, the passage of bowel gas in the urine. One of the known diseases, the gas from where will come to the urine. So there must be a communication, say, with the bowel, like in the diverticulosis, or so some vesico-enteric fistulae, to the small bowel or to the large bowel. So some of the gas from the colon will go to the urinary system, and just on passing the urine, there will be some gas coming out. If we are talking about pyuria, pyuria pus in the urine, infected pus, whether from the urinary tract itself or being fistulating to some other area, so it is giving pyuria and the clear pus coming out. Hemospermia. Sometimes you could have some blood in the sperm in the urine in the young men due to a disease or another. If we are talking about anuria, no single drop of urine being found by the kidneys, the patient is in cardiac insult, acute tubular necrosis, or a chronic insult, urine becoming less and less and less, still no urine. If the patient coming with oliguria, by oliguria is meant a passage of less than half a milliliter per kilogram body weight per hour, and this is to be considered very well, really. And if we are looking to the polyuria, think of polyuria very well, whether it is due to some sort of disease like recovery from acute tubular necrosis or a diabetic patient or secondary to an infection. So type of your patient and type of presentation will dictate our mind how to interpret such symptoms specifically to each one. Retention of urine being very crucial to understand. We are, as we mentioned, really, acute versus chronic retention. How to differentiate? Severe abdominal pain and mostly suprapubic, but no pain in chronic retention compared to the acute retention. History of repeated, and in such a patient, there could be some repeated UTIs, there are secreted of stone or stone passages, bladder neck obstruction like senile enlargement of prostate, trauma or operations had to be, to be interpreted from the patient. According to the type of the patient, retention of urine cause could be interpreted, it could be understood, say by an infant, very important in infants who cannot pass urine freely, think of posterior urethral valve. And by posterior urethral valve, as we mentioned in our lectures, that's to say the urethra will allow the fluids to go from out in from the tip of the urethra to inside the bladder like any negotiation of the bladder, but the urine, if it is formed in the bladder, it cannot go out because simply because there is a valve, one-way valve, which cannot permit the urine to go out, and its diagnosis and then its treatment by some sort of urethrotomy in an early stage, it could, be good and treat your patient rather than to come into renal failure later on, just to clear the urethra from this valve. In schoolboys, enlarged bladder neck obstruction in the schoolboy children. Better, it's good to know that, or a stone being in that boy, and of course, it is not simply a stone. You are to look at the metabolic disease, like a parathyroid problem, like some other metabolic disease. Why stones are being formed in this schoolboy? Better to investigate and know the cause so as to treat. In adolescence, in adolescence, they are victims of urethritis every now and then. So let us consider that. In the young adults, urethral stricture is secondary to urethritis, frequent urethritis, or some iatrogenic structure, or not iatrogenic to the urethra, um, if it could happen. The type of our patient, always I am stressing, look at the type of your patient. If from that you can judge what could be the cause, and secondary is to treat, of course. In the elderly, let's look at the prostate, at the carcinoma of the prostate, or the bladder, or the nearby structures. In the elderly, is definitely call for carcinoma. Look for the spinal cord injuries, really, if there is any in such patients. In female, it's uncommon, but post-operatively and postpartum could be a cause in some even of the young ladies. Simply in a patient with post-hemorrhoidectomy and he is not giving enough analgesia, he could go in retention of urine. So just to treat the post-operative pain, the patient simply will be treated from this type of retention of urine. If you are talking about urogeuria or anuria, as we mentioned, again I am mentioning uh, oliguria is just have the definition really. passing less than zero point 0.5 milliliter per kilogram per hour, but by anuria. Anuria, as we cleared before, it could be due to one of three main causes, either pre-renal, like some sort of hypotension, whatever the cause, then, or it could be secondary to renal, proper intrinsic renal pathology, or post-renal, that's to say, secondary to obstruction by stone in the ureter, or a bladder neck obstruction, or enlargement of the prostate. Before going, if we are to examine our patients, we are to take fairly very important precautions so as ourselves not to transmit disease to the patients and to protect ourselves from any secretion, specifically in the urine of our patients. So you are to have the gloves whenever you are examining your patient, especially if you are going to examine the prostate, the urethra, the contaminated area. Better to have some sort of tank depressor. Those are the usual tools for examining any patient mostly, but specifically in urology, we do like to have this. You have a pencil or marker. You are to have some sort of meter so as to measure the length or width of a certain swelling. You are to have some sort of a magnifying lens, even like some microscopic or a small lesion, so as a detail for that to have to have a hammer or something like to test for the tendons or if there is a spinal injury with it. Anyhow, the idea is to protect yourself whenever you are examining your patient routine or on emergency basis. Let us take the examination of the renal system as organ by organ. That's to say, we shall examine the kidney to start with, examining the ureter if we could examine the ureter, to examine the urethra if we could, to examine the bladder, and so on, and the PR at the end, to examine for the prostate, of course. For the kidney, as we mentioned even earlier, that palpation of the kidney, we are to palpate the kidney while the patient is being supine on her back or his back or on the lateral side, and preferable to put a pillow beneath the knees so as to have some relaxation of the abdominal muscles on that area in the loin, I mean, especially on the diseased side. Normally, the right kidney sometimes is palpable in its lower pole, normally, and it's firm, smooth, and rounded whenever it is normal. The left kidney is not palpable. This is normal physiological, by the way. Look at this picture whenever we are the methods to examine the kidney, either by manual examination and make sure your patient is having complete relaxation of the abdominal muscles, and the examination is being done by the palps of each hand on both sides, one in the loin and one anteriorly. And both sides and the palps are being approximated. You see here the palps of the fingers are being approximating. This is going anteroposteriorly, and this other hand is postero-anterior. I try to feel it, and it is better to be felt during expiration, really, because having less lax muscles and easily you can feel it. So expiration after deep inspiration. Ask the patient to take deep breath, then a deep inspiration, deep expiration, then deep inspiration. During this period, you could feel easily the kidney and whatever coming from the kidney swelling or a normal thing on the right side, like the lower pole. But on the left side, of course, it could be a pathological one. By one hand examination, so the first examination is by manual. By one hand examination, either in the kids or in the very thin people, and it is done mainly by the thumb and the fingers. If you can feel, if you can do the thumb and the fingers in the very thin patient or children. The patient is here supine, and the patient is in the left lateral position, so as to examine it properly if it is by one hand or by the two hands. There is something called, look at the patient how being sitting in here and how we are doing the Murphy's kidney punch. It's called a renal angle test. By renal angle test is intended to detect the deep-seated tenderness. The patient sits up, folding arms in front of the abdomen. And this is the renal angle test, just jabbing pain, so as to see how your patient, or jabbing pain, I mean, so as the patient will see, whenever you are pressing firmly on this angle, your thumb is placed under 12th rib, and jabbing movement is done, and this will be increased in intensity. Of course, we don't like to cause pain for the patient, but at least a deep tenderness will be there, and the patient will show that. Coming to the renal swelling, it's always very important if you are talking about the renal, how to what are these characteristics of the renal swelling. And it's traditional, if you are talking about renal swelling, to differentiate it from the splenic swelling, if it is on the left side, of course. But specifically for the renal swelling, of course, in the line here, on the right or on the left, there could be a colonic swelling, there could be a post or erythroperitoneal swelling or a renal swelling from whatever the cause. But coming to the characteristics of the renal swelling, it is characterized to be in the line, kept the kidney shape smooth, the outline, if it is not just an irregular tumor. More with moves, it moves the renal swelling with respiration, but on percussion for renal swelling anteriorly blood, there is a band of resonance of the colon, but dull posteriorly. So the colon is in front, there is a colonic impression on the kidney. So if you are doing some sort of percussion of the kidney anteriorly, there will be some sort of resonance. The colon will be resonant to that, but posteriorly, it is the kidney is situated or sitting on the on the back muscles, so it is dull posteriorly. There is a ballottement a test, and it is a specific for the kidney. If we are saying there is a ballottement in that swelling, so it is pathognomonic word to say that, or to tell us that it's a renal swelling. So examining fingers and how to do the ballottement, examining fingers of both hands cannot be placed between it and the lateral border of the erector spiny muscle. This is how to do the ballotment. Enlarged left kidney, how to differentiate between enlarged left kidney and the spleen. This is very traditional for our medicals. Please make sure you are perfecting this or knowing that. If sharp anterior border and there is a notch, those are characteristics of the spleen. And the spleen, as you know, it is being enlarged from the left hypochondrium, let us say, and it will be enlarged going to there to the right iliac fossa. And if you are to ask it to examine the spleen, please go from the right iliac fossa and go up to the tip of the 10th rib so as to reach the spleen in a better way and a very systemic way. Ballottement equals kidney swelling unless externally adherent to the surroundings. Spleen enlarged to the right iliac fossa, that's to say inferior and medially, and the kidney enlarged medially and posteriorly. You know, there's a difference between spleen and kidney. Dull palpable swelling sometimes going with the spleen, and it could be splenic swelling, but keep in mind that renal swelling could be dull posteriorly still. For the differential diagnosis of renal swelling, please think of congenital cystic disease. And congenital cystic disease, as you know, it could be manifested only in the middle-aged group between 30s and 40s, but still in the young could be, and in the elderly could be there, you know. An ectopic kidney, please make sure. You know what we talked about the anatomy, let's say what is called as normal anatomy, but plenty of anomalies in the kidney, as we mentioned in our congenital anomalies of the urinary systems, whether in the kidney, in the ureters, in the bladder, in the urethra. Keep the congenital anomalies there. So ectopic kidney, and ectopic kidney could be in the right iliac fossa or horseshoe kidney. It's just in the suprapubic area. Just think of that always as a cause of abdominal lump. Congenital malformation of the kidney, the double ureters, hydronephrosis, horseshoe kidney, and other malformations could be presenting swellings in our patients. So for the renal swellings, let us mention some of them. For tumors or neoplasms of the kidney, the common tumor in the elderly, we are talking about adenocarcinoma or renal cell carcinoma, or we are calling it sometimes Gravitz tumor, the commonest renal tumor in adults. Keep it in mind. And please, coming to the pathognomonic triad of this tumor, patient presenting with this loin swelling together with the gross hematuria and sometimes occasional hematuria, mostly it is hematuria, and those are pathognomonic to the renal neoplasm. Presentation painless could be, or pure with intermittent hematuria. Presentation could be mets in the bone, metastasis in the bone, or acute varicocele. Very important to put in mind. If an elderly coming to you with acute presentation of left varicocele, which was not existing before, think of renal cell carcinoma, which could metastasize to the renal vein. Very important to know that, and obstructing the drainage of the gonadal vein, and an ultrasound simply or a CT scan have to diagnose that. Pyrexia, sometimes pyrexia of unknown origin, generally speaking, it could be secondary to this neoplasm. Pyrexia could be intermittent, could be plateauing sometimes, but mostly it be intermittent fever. In children, on the contrary, we are not that the nephroblastoma or the Wilms tumor, the commonest tumor, because commonest tumor, renal tumor in the children, second commonest a childhood tumor discovered accidentally by could be by the mother going while dressing her baby. One is sorry really just to discover a big swelling in the loin or going to the abdomen even, the mother will come and say, oh, come on, there is a big tumor in the big, thing in the abdomen of this patient. And on that basis, you are discovering this big swelling in the tumor in the kidney. Going back to the history, the mother will say, yes, the urine could be sometimes discolored in a hematuria-like, but unfortunately, the patient could present a cell with some metastasis in the bone or metastasis in the lungs, sorry, metastasis in the lungs, but it is kept to one side. It's very, very aggressive disease in children, if not discovered earlier. Renal swellings by, one of the very important swellings in the lung, really. Look at this swelling in the loin on the left side, coming the perinephric abscess. If a patient coming with fever or unknown fever, or a cold abscess or something like that, cold abscess is tuberculous abscess, of course, what is known as perinephric abscess. And the clinical diagnosis for that, yeah, put it clinical diagnosis. Inspect for full renal angle, scoliosis lateral curvature of the spine, pushing the spine to the other side. This is very important entity to think of really. Palpate the renal angle, this Murphy's sign could be positive. Murphy's renal angle sign could be positive in this patient, just exerting some pressure or rubbing pain, as we said. If you are coming to the next, from the renal pelvis, is the ureter coming out. The ureter pathologies in the ureter are very simple, really, and it could harbor a calculus or a stone inside, and the patient could have some pain in the right iliac fossa, which could be radiating still. Pain is characteristic. The ureteric colic is characteristic, as we mentioned. Pain at different parts of the ureter, it could indicate the site of the impacted stone, as we said, at the pelvic brim or near the ischial spine. It means that, if pain in the tip of the urethra, it means stone there near the ischial spine in there by an X-ray could be detected. We have mentioned that. Can the ureter be felt? It's a question always. Could we feel the ureter? Normal ureter, we cannot feel it. But Tuberculous ureter, yes, TB. In the ureter, you can feel it just in the lower part of it, abdominally or even vaginally in some of the patients. Calculus in the lower ureter could be felt during a vaginal examination in the ladies. So just make sure. But of course, try to diagnose this before reaching this point. But you can do still. By the urinary bladder, always it's a golden rule of thumb. Always empty the bladder before any abdominal examination, specifically if this is swelling, is suprapubic swelling. Sometimes the only presentation of the patient is the suprapubic swelling, and you think you have discovered there is a big mass in this patient. And if you put a full catheter, oh, that mass will go. So please try to empty the bladder before any abdominal examination. And the bladder being distended either by acute retention of urine or a chronic retention of urine, that's to say retention with overflow, and the patient will present with dribbling of the urine, no pain if it is a chronic retention, or there is a little pain just by pressure. By examination, there is a pubic fullness, exactly like this here. This is the umbilicus, and this is the pubic fullness in this patient. If you did an ultrasound, the bladder will be shown like that. There is a pubic fullness, increased pressure on the deep palpation, and so, you know, and giving the desire to micturate or increase the dribbling of the urine whenever you are pressing on the on. Other bladder-related pathologies, of course, think of diverticulum of the bladder. Bladder having a diverticulum, there is a swelling. That diverticulum connects some part of the urine in there, and it could have some pain if you press on that. Carcinoma of the bladder, carcinoma complicating a granuloma of the bladder sometimes. Or you could have some sort of ectopia vasica whenever a newly born fetus or a newly born child being born and the bladder is being open to the abdominal ectopia vasica. And on that basis, this is an emergency and pediatric surgeons are to be notified so as to repair it to the patient. Coming to the female urethra, it's very important to know the distribution of the female urethra, the position, anatomical position of the urethra. If we are talking those about the labia majora, and here is the labia majora, here is the clitoris, here is the opening of the urethra, say, and here the intercoitus, it's very important to know this area very well, really, because whenever you are going to pass a Foley's catheter, know that you are passing the Foley's in the urethra itself, not in the vagina. It's very important. Sorry to say that, but sometimes it will happen. How to examine the urethra in a patient, specifically in the female. The position is mostly is a lithotomy position. That's to say, on her back, and its size being abducted so as to open the area and to see the urethra very well. Sometimes we could have some sort of urethral carbuncle, an infectious process, swelling is coming in there, and you need to treat that. بنسميه Roseberry tumor from the first posterior wall of the urethra. It's very important. Whenever the patient is passing on it, you will feel the pain and the problem in there. Sometimes ladies are shy to talk about it, but take history in a fairly respectable manner. You could get everything from the patient. This is when it could be tender, I mean the carbuncle. It bleeds easily, but make sure there could be a carcinoma in that area still, or some other pathology or a granuloma. But there is a urethra, just at the urethral opening, there becomes something coming from the posterior wall of the and coming. You see here, the carcinoma of the urethra itself, from the urethral opening, and the incidence is from 2 to 1 and more in the female, really, as it's clear in here. So this is a neoplastic tumor coming from the urethra itself, and the drainage of this swelling will be to the inguinal area here in the inguinal lymph nodes. So it's very important if you see such a tumor go to the drainage area, I mean the inguinal lymph nodes in this area, either to the left or the right. This is very important to put in mind, not to leave it like this. It had to be biopsied since for histopathology and see what source of a tumor in the urethra. Of course, the tumors or neoplasm in the urethra are transitional cell carcinoma according to its lining epithelium. Sometimes you could have a prolapse of the urethra. Your finger itself totally could be put in the urethra, being part of the posterior wall, part of the posterior urethra coming out whenever she is passing some urine. And better to think of it whenever you are having such a swelling. And this is diagnosed clearly on standing and incomplete. Sometimes it could be complete or incomplete. By incomplete, this means eccentric opening of the urethra. But by complete prolapse, there is central opening and mostly like completely prolapse of the urethra coming out. Other diseases in the urethra, definitely there is some sort of urethritis. Of course, we could see nothing in the urethra, but this could be diagnosed by yes, could be some induration, some swelling, tenderness, but on passing tenderness, but pain on passage of urine will be there. There is stress incontinence could be especially in the ladies. There is urethrosil. Sometimes there is, some urethrosil. Sometimes, some swelling or cystic swelling from the urethra coming out with the urethra. This is the last but one slide really, how to do digital rectal examination. And always we are saying never finish your abdominal examination, whether for a lady or for a man, whether being elderly or a young man or a child, without doing PR. This is a golden rule for abdominal examination itself. But here, for a digital rectal examination, it is intended really mainly to examine for the prostate in urology, to examine for the bladder pathologist. Sometimes it's very important how and where to examine the patient and how to put your patient for examination. So we postulated some guidelines, which is the standard. Of course, whenever you are approaching your patient to do a PR examination, definitely, if the patient doesn't know you, of course, you will introduce yourself to the patient. Ask, ask his or her permission while to do this examination and explain for your patient what you are going to do. She could have some pain, he might not have some pain, he'll have some swelling, but if there is any pain, she or he are to notify you so as not to stress on the area. Of course, ask where is the pain mostly so as to be away from the pain whenever you are starting. So you are introducing yourself, you are explaining what you are going to do for the patient, the position. The position we are having different positions, could be four positions at least. Number one is the lithotomy position, is the easiest. And this is the one we are doing mostly while you are in your office or if you are in the operation room, but you are on your outpatient clinic. I prefer really and advise you just a left lateral position could be a very reasonable one. Left lateral position, while the patient is more or less something like squatting, the knees going to the abdomen and opening the anal verge and use your index in the right hand to examine the patient, of course, lubricated, gloved left index finger and to go slowly in the patient and while you are talking to the patient and explaining why you are. So the first position is the lithotomy one. The other is the left lateral position or right lateral position, of course. Then, or the other position is the standing bent, and you can do that bent over, of course, as if you are the tirka. In Arabic, we are saying tirka, as if tirka while if you are praying, or the knee chest position if you are looking for some other position. So, four positions. I advise you from the practical point of view, go for the left lateral position, covering all your patient, explaining everything for the patient, have the confidence of the patient in you while you are doing that. Wear disposable gloves. It had to be disposable gloves, of course, and by lubricated index finger
to examine and explaining for the patient we are doing. Of course, you are starting by separating the buttocks so as to see the anal verge. Number one, as we know, any organ to be examined by number one, inspection, palpation, percussion, auscultation. Of course, here in the anal verge, we shall inspect and palpate mainly. Separate the buttocks and inspect the anus for any piles, for any fissures, for any pathology, for any condyloma, for any other pathology, for a skin disease. This is by inspection. And now you are going to do palpation. Gently insert the located index while comfort of the patient. Don't let your patient say, why are you examining the patient? Okay? Waiting for a few seconds to start with little external and its internal sphincter being relaxing. Waiting for a few seconds will relax the anal sphincter, allowing introduction of the entire finger inside. While going inside, it try to feel exactly in any pathology coming in hands, like swelling, like a tender point, like the mucosa of the rectum, or to start with the mucosa of the anal canal, then going to the rectum, and look while you are introducing the finger about any swelling or other pathology. Go slowly, firmly, and in a circular way, let your index finger rotate or moving in the rectum, palpating the posterior prostatic surface. You are palpating the posterior prostatic surface just anterior to the smooth rectal wall, and the rectal wall is not attached. So the rectal wall is intact, and in front of the posterior rectal wall is the prostate. Look at the prostate. How does it feel? Rubbery, solid, any solid nodule in there. By the way, solid nodule in the prostate might indicate you, or you could discover a prostatic carcinoma of this patient. Look at the furrow in between the two loops of the prostate. Look at the consistency. Look at the tenderness. Try to feel the tenderness, at which part is being tender. And there is, by examining the prostate, there could be some prostatic secretions coming out through the urethra. So tell your patients, or the patient can tell you, there is something coming out from that urethra, and if there is something coming out of this urethra and your patient is the symptoms of prostatitis, please take that for analysis, for culture and system. So be very gentle, very confidentially going this process in your patient so as to do it properly, and the patient will give you the chance to examine him or her perfectly. This is just look at this one. This is the index finger, this diagram, and this is the anal verge, and this is the rectum, and this is the rectal wall. This is the prostate, and just anterior to it is the bladder. Try to feel everything in a nice and very uh, confident way. Look at the anal tone. What is it? Is a normal anal tone, or a patulous anus, or a fissured anus, or whatever pathology? Just give signs. No need to diagnose now, but give us signs. This patient is having a tight anal sphincter. This patient have a patulous sphincter. This patient is having an ulcerated anal skin and perianal and just inside the mucosa. Look at the anal and anorectal masses. Look at the prostatic size. Normally, it is the size of a chestnut. Chestnut يعني الكستنة. Look at the prostate consistency, normally as a contracted, like a thinner eminence, like our thinner eminence in the hand. Look at the prostate symmetry, left and right symmetry of the lobes or nodularity. Both lobes are symmetrical normally. Palpate for the prostate nodule or irregularity, then in duration of the bladder base itself, the bladder base, look at it if you could go more anteriorly or just superior to the prostatic or posterior, I mean, to the prostate so as to feel the bladder. Of course, if there are any tumors, go laterally here and there. You could feel some pelvic pathologies in the same patient. So at the end, try to clean the perianal area. Tell your patient, thank you for giving, yeah, thanks for the patient. That's okay. Just whip the area or mop it and let it be dry exactly as you started your examination. Cover your patient and tell the patient, yes, we finished. You can relax and come out, please. Record all your data on your file whenever you are taking history and doing examination. So do some diagrammatic illustration for your findings in this patient, and on that basis, clinically you can give a diagnosis by history and examination. Of course, this will be confirmed more by requesting some investigations, whatever imaging or a blood or urine or cytological or histological examinations to give the final diagnosis. Thank you for listening, and always I am ready for any question anytime. Thank you.